This is most common in males over age 55. They might have a smoking history, a chemical exposure. People in the military have a higher rate of bladder cancer, actually, just especially if they've been exposed to things like Agent Orange or those sort of harmful chemicals. Bladder cancer is a big one that we see with them. So always something we want to be thinking about. Obviously, if we catch bladder cancer or suspected bladder cancer, we're going to be referring them out for surgery, chemotherapy, radiation, those sort of things. Let's do a little practice question while we're wrapping up all our urinary symptoms. So we have a 35-year-old being prescribed antibiotics to treat a simple cystitis. Which of the following is appropriate for follow-up? So we have return to the office for blood work if symptoms persist, return after a urinalysis of 24 hours on antibiotics, return to the office if for a culture in 1 week to ensure reduction of the pathogen, or return to the office if you are not better in 72 hours. What would you say if you were the provider? And this is right from our question bank too. So if you know anything about me and anything about Archer, you know that I love practice questions. So what are we going to do with this patient? We want a second here. All right, let's see. So the answer is D. So if these symptoms have not improved in 72 hours, we're going to have them come back. We wouldn't really have them come back for blood work if their symptoms weren't getting better. We definitely get that urine culture to see what's going on in the urine. So that's why choice A was incorrect. Choice B is return for a urinalysis. Again, no need to get confirmation from a urinalysis for an uncomplicated UTI if they're feeling better. And then choice C, we don't need them to come back for a urine culture of resolution if their symptoms are getting better. Just kind of an unnecessary thing. And again, we always want to think about being cost efficient providers. So that's not really a cost efficient thing to do. But if this patient's not getting better after 72 hours on antibiotics, I want to know about it because either it's the wrong antibiotic choice or something else is going on. So always send them home. And, if you're not getting better, you got to give me a call back. And that wraps up our GU. So let's talk about STIs, which is definitely something you're going to encounter if you are working in primary care or in a variety of other settings. So let's talk about our first one. We have chlamydia. So chlamydia is a tricky one because it's often asymptomatic. And that's why a lot of offices and the CDC recommendation is to screen people more frequently because a lot of people with chlamydia have no idea they have chlamydia. Or they might have like slightly strange vaginal discharge, but it's not concerning to them. So they're not doing anything. They're not worried about it. A lot of times with males, they have no symptoms at all. So they may be spreading it unknowingly. Some symptoms might show up like abdominal pain, irregular bleeding with people who have uteruses, burning with urination for men, and then maybe some of that white watery penile discharge. Exam findings. So again, might be totally asymptomatic, or they might have some abdominal pain. And if they have a cervix, cervical motion tenderness. So, if you were to do a pap smear and touch that cervix, woof, very painful to them. So if that ever happens, definitely put on your alarms that something's going on here. We test with the nucleic acid amplification test, so an NAAT, which tests for a lot of our STIs. We can do this in a clean catch urine. We can also do it in a swab. So a lot of offices screen basically everyone for chlamydia, especially in that younger college population where we do see a lot of cases, especially asymptomatic cases. And that can be done easily with the clean catch urine. So nothing invasive. The treatment for chlamydia is not Rocephin. It's doxycycline. That is the newest recommendation. So that came out a couple of years ago. It used to be azithromycin, and we also used to give Rocephin to double treat chlamydia and gonorrhea. But now we moved away from that, and we really treat them separately because we have better testing at this time. And where'd my little cursor go? Oh, there you are. Moving on to gonorrhea, it looks like the treatment slides got flipped here. So gonorrhea's treatment is Rho7 and chlamydia's treatment is doxycycline and azithromycin, but they do go hand in hand a lot. So we often are treating both of them at the same time. So gonorrhea is, again, often asymptomatic. A fun fact about gonorrhea, which is something that the boards like to ask about, is it's the most common STI in those with HIV. So something we're always testing those patients, obviously, for any sort of infection, but one you want to have on your radar is definitely gonorrhea. So again, it might have that yellow-green vaginal discharge, might see some burning with urination, might have some lower abdominal pain, but usually completely asymptomatic. And we do test for it in the same way, that clean catch urine or that vaginal or penile swab. An important piece for most STIs is we want to treat partners as well. This varies by state, who you can treat. So some rules allow you to send, an extra set of antibiotics. Some make the patient come in for their own set of antibiotics. There's a wide variety. If you are a family nurse practitioner and you see both partners, even better, because you can just prescribe to each partner. But look up your state regulations and then also your organization's regulations. So, does your organization allow this? How do they handle it? But ideally, we are treating all partners that they've had recently, so we are able to get rid of it all. There's a large stigma around STIs that we do try to educate on. They're just infections. They are obviously sexually transmitted, but we want to treat everyone, get rid of them so there's no complications, especially gonorrhea. There's a lot of drug-resistant gonorrhea happening. So we want to make sure that we are treating it, getting rid of it before it becomes drug-resistant. Moving on to syphilis. So syphilis, the primary lesions show up as small, painless lesions. So a really important thing, especially for your boards, is they will be painless. If a patient comes in, they're like, I've had these weird lesions, but wasn't worried about them because they were painless. Red flags, alarm bells going off that this might be syphilis. If that's not treated, syphilis moves into a secondary stage. And in that secondary stage, there can be a rash on the hands and feet, and they might have flu-like symptoms as well. So if that's on your boards or in real life, they say, I had this weird painless lesion that kind of looks maybe a little bit better. Now I have this weird rash on my hands and feet. Definitely thinking syphilis. Tertiary. So if this has gotten really bad or it's just gone unnoticed or untreated, we can have neurosymptoms and valvular disorders. So in the heart, those can actually become ruined by syphilis or infected by syphilis. Syphilis testing is the RPR-VDRL as the initial test. Now, this is really something important to know about this test. This can come back transiently positive. And sometimes this happens in patients who might have something like lupus or rheumatoid arthritis. Sometimes I've even seen it come back positive in patients with Lyme disease. So that RPR-VDRL is not the confirmation. That is the screening. If it's negative, great. No need to reflex it. If it's positive, we're not going to call it syphilis 100% until we get that FTA-ABS. In my head, I call this the fat abs test. I know it's not fat abs, but it's just how I remember it. So we reflex to the FTA-ABS. If that's also positive, it's syphilis. If that RPR-VDRL is positive, but the FTA-ABS is negative, start thinking of other causes or repeat the testing. It could have been an erroneous error. Some things can happen. There's a lot of literature out there about what can elevate that RPR-VDRL. So I've had patients with rheumatoid arthritis where they always test positive on the RPR-VDRL and it's never syphilis. It's never positive on the FTA-ABS. And another one, like I told you, is Lyme disease. Actually, the inflammation from that can cause those erroneous positives. If it is syphilis, we love to treat it with the gold standard benzathine penicillin G or bicillin. There is a current shortage on bicillin. So if you work, you might know that we are having a hard time getting this, but it is really the best to treat syphilis. If there is a penicillin allergy, there can be some treatment with doxycycline or other treatment options, but This is a case where you really want to dig into that allergy. Did they just get a rash when they were a baby? Did they have an anaphylactic reaction? What's going on there that they are saying they're allergic? Because that bicillin really takes care of the syphilis. And this is not, it doesn't matter the stage. We treat it with the bicillin no matter the stage. The treatment longevity just changes. So the dose changes based on the stage. And that is an IM injection. Some places carry it, some places don't. The ER usually has it. Sometimes they can help you out if you have a patient with syphilis, or a lot of primary care offices do stock it, which is nice for patients because a lot of times if it's that primary lesion, that primary stage, one-time dose, and they're good to go. HPV, caused by human papillomavirus, is a virus that causes genital warts. It can cause things like cervical cancer, anal cancer, throat cancer. I'm sure you all are well read on HPV because this has been like the one of the greatest accomplishments of the early 2000s up to now is that the vaccine for HPV, the Gardasil 9, has decreased cervical cancer rates so tremendously that we've actually changed the cervical cancer guidelines. So that is really a huge win for us as human beings, is that we've essentially almost eliminated a type of cancer because of a vaccine for a virus that causes cancer. But HPV has hundreds of strains. So there's only a few that cause that cancer. There's over 100 types of actual HPV, and most of them the body clears out on its own. So a lot of times if you have a patient who has HPV, which you usually pick up on a pap smear, so it comes back ascus or something like that, and then a positive HPV, if it's not a high risk HPV, that's why the guideline is to just retest them, because normally the body can clear it out. A little pearl here on HPV is it can show up way later in life. So if a patient's been with their partner for 50 some odd years and all of a sudden they test positive for HPV, don't let them freak out, because they will, how did I get this? What's going on? It can lay dormant for years and years and years, and something like stress or anything can cause it to pop up and be caught on that pap smear. Or their previous pap smears were just at a time when their viral load was low and it wasn't being detected. But again, there are only some that are related to cancer or long-term issues, which the vaccine protects against. So just because they have HPV, it might not even be a type that's related to cancer. And then we have types 6 and 11, which are really closely related to the warts. So not cancer, but vaginal or genital warts. And a note about the HPV vaccine, it used to be just females, then it used to be females and males up to a certain age. Now it is approved to everyone up to 45. So something to educate your patients on, right? We know that people don't stay with the same partners forever. If they've never had HPV and they have a new partner, they can be exposed to it. And up to age 45, it is recommended now to get the HPV vaccine. So it takes a lot of education, especially because we do start this technically at age 9, they can start it. Usually we start it around age 11. And there is a lot of education with parents around, it's not going to make your child sexually promiscuous or anything like that, or encourage them to do things that they're not ready for. It's just to protect them in the future. And if you get it before age 15, you only need 2 shots versus after age 15 where you need 3. So there's like a little bonus in there too on less vaccinations, less shots. But it takes a lot of education. There is sometimes a little bit of a stigma around it for whatever reason, even though we know this has been such a great breakthrough. So moving on to something more serious, pelvic inflammatory disease, PID. This is more uncommon, but is a very serious infection of the uterus, fallopian tubes, and even sometimes the ovaries. So really, really detrimental to these patients. The most common cause is untreated STIs, which again is why it's so important we're screening everyone, right? We can do that quick and catch urine for gonorrhea and chlamydia, or can test them for syphilis, things that we should be testing for in patients who are sexually active. So things like pelvic inflammatory disease do not occur. So on exam, you might again see that skull motion tenderness. And this is a time when we need to figure out what STI is causing this. A lot of times it is related to chlamydia, which is why we go for that doxycycline and then the metronidazole, which is Flagyl. We usually do this together for 14 days just to wipe out everything. If you were with me for our other webinar, we talked a little bit about Flagyl. So this can be used for things like BV, which sometimes can play a role in pelvic inflammatory disease. And we know, again, chlamydia does as well. So that's why we usually go there. Plus that Rocephin injection to cover any gonorrhea, because again, gonorrhea and chlamydia are best friends there, and they can cause pelvic inflammatory disease. This is a time that we're really not messing around. We're not waiting. We really want to get this treated because this can get very very quickly. Fitzhugh-Curtis syndrome is a complication from pelvic inflammatory disease. So this is when the infection reaches the liver. So this is very serious, and they might have that right upper quadrant pain when they're taking a deep breath. They might have the fever and the chills, cervical motion tenderness, same treatment as pelvic inflammatory disease. So we're going to give them that doxycycline, ceftriaxone, and that metronidazole just to cover it all, get the infection out of there, and move on. But this randomly is something the boards like to ask about. So if you see Fitzhugh-Curtis syndrome, now you know it is a complication from pelvic inflammatory disease. So don't worry if you see this on your exam, you know what it is and you know how to treat it. Reiter syndrome, on the other hand, is a complication from usually chlamydia, could be any STI. This, interestingly enough, causes joint pain, conjunctivitis, and then urethritis, which makes sense because the urethra is right there. But the joint pain and conjunctivitis are something very specific to Reiter syndrome caused by usually chlamydia or any other STIs. Interestingly enough, this is a self-limiting condition. So we usually just do symptomatic care. Obviously, if they have an underlying STI currently, then we're going to treat that. But we can do things like NSAIDs. In extreme cases where that joint pain doesn't go away, we might need corticosteroids or DMARDs, but usually this does resolve on its own when the STI resolves. HSV, not to be confused with HPV, is herpes simplex virus. Herpes simplex virus comes in two varieties, HSV1, which is most commonly oral. So that's something like an oral kink, cold sore. Abreva is the most common treatment for things like that. It can be genital though. So if people are having oral to genital sex, they can get HSV1 in their genital area. And then HSV2 is most commonly found in the genital area, although again, could be oral as well. HSV lives in many people who have been sexually active without any symptoms at all. And that's why it's so hard to catch. And even if we do catch it, there is a blood test for it, but we're not screening everyone for it because if you don't have symptoms, we typically don't treat it. Sometimes in pregnancy, they might treat it without symptoms in like week 36 on, just to prevent any sort of lesions from popping up. So the fetus, when they're coming out vaginally, doesn't get touched by the lesion and cause the fetus complications. But generally, we are not just testing for HSV without symptoms. If we do see symptoms in a patient, so, they have those sores, they have fever, they have swollen nodes, usually that first outbreak is the worst outbreak. Then from there, some patients never have another outbreak. Some have more frequent outbreaks, but we would do that PCR viral testing. So just a swab, it's pretty uncomfortable for patients. So just know that if they're swabbing a lesion, they're really, really tender. So just be aware of that. Tell the patient it is going to be uncomfortable, unfortunately. And then most effective treatment, early on, 48, 72 hours of symptoms, we want to get them some antivirals like acyclovir or valacyclovir. And again, caution in pregnancy. So if we had a pregnant patient and we're worried about this, or we have a positive HSV test, we definitely want to let their OB team know so that they can treat them prior to delivery, so the fetus doesn't rub on any of those lesions. But HSV does carry, and I find this in my own practice, a big stigma. So a lot of patients don't know that the majority of the population does carry it in some capacity, whether it's HSV1 or HSV2. And we can work as providers to really help take away that stigma around it. Say, this is just a virus. It's with you forever, unfortunately, but there are things we can do. We can do antivirals when you get symptoms. Some people, if they get symptoms a lot, take antivirals for a long time, so they take them daily. And then there are a lot of research studies around HSV and curing it, just because we do know that so many people carry it. And although it doesn't cause long-term issues in most people, it is something that affects many people. So just some things we can do to help patients understand. I have a whole spiel I go into about HSV because it is very, some patients feel very embarrassed by it, things like that. And our place as providers is to empower them with the knowledge to help them get over, that embarrassment, help them talk to their partners, those sort of things, just so we can get them the proper treatment so they don't have those outbreaks. But like I said, the original outbreak, the first outbreak, usually the worst. From there, it usually gets better, and they might just have little lesions that pop up every now and then without the fever, chills, swollen nodes, all that stuff. So we've come to the end of our content, but let's do some practice questions because I love them. So the nurse practitioner is conducting a lecture for high school students regarding sexually transmitted diseases. Which of the following can be prevented by vaccination? So is it syphilis? Is it HPV? Is it HSV, or those genital herpes? Or is it trichomoniasis? Which one do we have that really great vaccine for? Everyone, just a minute here. Looks like everyone's answers are correct so far, which makes me very happy. It is HPV. So we have a vaccine for HPV, which we know. We don't currently have any sort of syphilis, HSV, or trichomoniasis vaccines, but maybe someday. The world is our oyster. It may be found out someday, but we do have that HPV vaccine. Again, that decreased cervical cancer rate so dramatically that it actually changed the protocols on how we deal with pap smears, which is honestly amazing. Let's move on to practice question 2. So in a gynecologic exam, the provider, maybe you in this situation, assesses the external genitalia and sees a shallow, small, painful ulcer on a red base. Which of the following is most likely? Is it a genital herpes or HSV ulcer? Is it syphilis? Is it a genital wart, or is it a chancroid? So painful is the word I'm looking here to help me out. So we talked a little bit earlier about painless ulcers, but this one is painful. Looks like everyone's coming along with the right answer here. So if you said A, or HSV, genital herpes, that is correct. So painful shallow ulcers, HSV. Painless ulcers, syphilis. So those are some key words, and you're all doing a really great job with that. On your exam, look for those key words. If it just said an ulcer, it could be a million things. But if it's saying painful, painless, why is it saying it? The boards are not there to confuse you. As you can see, our question bank isn't here to confuse you either. And you all picked up on the fact that it was a painful ulcer, which would lead us to HSV, versus something like a painless ulcer, which would be syphilis. And then genital warts, which can be caused by HPV, so human papillomavirus, generally are not painful. They also are not ulcerated. They're more raised up. If you've ever seen like a plantar wart, like on someone's finger or foot, it looks about the same, just in the genital area. All right, everyone. Well, we have reached the end. What questions do you all have? And then I'll talk a little bit about our offerings for FNPs and AGNPs here, Archer Review. But hit us with any of your questions. Can be about this, can be about boards in general, whatever you've got. Hey, any questions? I do see some repeat people here. It's nice to see you all again. And we do have these every Monday. And this week we also have one on Wednesday as well. You can follow along with our Facebook page or our Instagram. We are going to start having a couple different webinars a week. We're going to do different topics, some case studies, everything and anything to get you prepped for boards and practice. They're helpful even if you've already passed your boards. So we hope you can join us. And if you have friends in FNP world or the AGNP world, or even, the nursing world in general, have them come on by. So if you have any questions, you can throw them in the chat and I'll just talk a little bit about what we have coming up here at Archer Review. So we have our question bank, and right now we have 1,400 questions, although it's like a couple questions away from 1,500, and we are actively adding more. So we add questions every single week to the question bank. And it really is a good way to assess where you are. Our goal is to make it a really robust readiness assessment for where you're ready to test on your boards. And when you get to those boards, you say, oh, I've seen this question before. I know exactly what I'm doing here. We are also working hard on on-demand videos, so you can review topics like this anytime you want. And then very soon we have a live 3-day review coming. And this is more of a quicker review style, but we're going to hit on every single topic you need for your exams or just practice all those big topics. And again, just like I said, we are going to be having webinars every week, a couple times a week now. So you can join in whenever you have time. We'll vary the times during the day, during the evening. I know some people work different shifts. And you can scan that little QR code to sign up for all our future webinars, or you can just go to our Archer Review website and sign up there for individual ones. You'll be able to browse. Next Wednesday, we have a cardiac one coming up. That's a huge topic for your exam. So that's actually split into 3 different lectures. Please follow us on social media. We have questions every week. You can message us there. We're always happy to help with board prep or licensing, credentialing, jobs, anything. We're happy. We are all a team of NPs here who currently work in the field and teach for Archer. So if you have any questions at all, you can always shoot us over a message or an email. Our email is fnp@archerreview.com. And someone asked if we know an estimated time and date for the 3-day review. So we don't have those nailed down just yet. I actually think within the next week-ish, we should have dates. So be following our Instagram and our Facebook. We will post it everywhere. I promise you will not miss out on those dates for the 3-day review. We are looking at a time frame of 1 longer day, so maybe 1 like 6 to 8 hour day, and then 2 shorter days. So you're not totally burned out, but we also don't want to cut out any important content, right? So we don't want this to be a sort of thing where you get through it and you're like, well, now I still have to study a ton because I learned nothing. So they do unfortunately have to be a little longer days, but plenty of breaks will be provided. We will have lots of Q&A sessions. You can ask our team who have all passed our boards, how we prepared, what we recommend, any questions about signing up for boards. I know sometimes schools just throw you out there with no information. So really, truly, you can ask us for before as well. Always feel free to send us an email or a message on social media. But that 3-day review is going to be designed to be pretty much everything you need to wrap up your studying, go ahead and pass your boards in conjunction with our question bank. As you know, I love practice questions. Don't cheap yourself out on questions. The more you do, the more likely you're to hit that exam and say, oh, I've seen this question before. I've seen exactly what they're asking for. I know the answer. And you'll, easily get through it instead of agonizing over those questions. All right. Any other questions before we wrap it up today? It was nice to see some of you again. It's kind of fun to see friendly faces over and over. Again, you can join us. This week we have some more coming up. Next week we have some more coming up. We're going to be hitting cardiac in 3 different sessions. That's a really big topic for the exam. So if you can, definitely join us. And if you scan that QR code on the screen, that will sign you up for all our future webinars. So 1 and done there, which is kind of nice. All right. Well, if there are no other questions, I think we will wrap it up. Again, if you have any questions at all, you can always send us a message on social media or email us over at fnp@archerreview.com. All right, everyone. I hope you have a fabulous week. I'll see you around on our socials. And again, send us over any messages you have. Have a great week, everyone. Thanks for joining us.